Assalamu alaikum. Is my voice clear?
وعليكم السلام ورحمة الله وبركاته دكتور خالد. واضح تمام.
معرفش كده شغال ريكوردينج. اوكي. Inshallah, this is the last session in diabetes chapter. 1 hour previously, I decided that dyslipidemia I prepare it, but 1 hour ago I review it and I think it need some revision, so I postponed the dyslipidemia chapter to the next Friday, inshallah, to prepare it well, because it needs a lot of modification and pathophysiology and needs some illustration to simplify it. So inshallah today we will discuss macrovascular disease in the diabetes mellitus chapter, and actually this is the sources for subspecialty examination and European board examination, and every time Oxford handbook is the only reference you need to study. Oxford handbook, this is the one of the most important references in the UK, and of course for examination. After that, try to solve a lot of questions which available in a lot of websites. Most important one is the best of 5 toolbook, study BRN, exam lab at every time. Exam lab is very, very important, and actually it contains 200 questions. In each exam they put about 25 or 30 questions from this source. And actually in the previous year we solve exam lab and they give a lot of comments about it, because in the website exam lab has no comment in the answers. So with Dr. Mahmoud Izzat and Dr. Ibrahim Al-Ali and Dr. Sufyan and Dr. Khaldoun and Dr. Nayira and a lot of, and Dr. Gopta, a lot of our endocrinology pioneers in the previous year share in these sessions, the previous sessions for solving of exam lab, and of course, and actually we solve a lot of these references based of 5 MCQs at toolbook, study BRN, and all these resources we review and discuss it in more details, and also it is available in the YouTube channel. After that, the website for European board and subspecialty examination have sample questions about 60 questions for everyone. And after that, of course, British Medical Journal examination, subspecialty examination have about 800 practical diabetes website. And don't forget that you must review all of the guidelines published by the NICE, especially the most important one. And actually we have in the previous year about 5-hour Zoom session for the most important guidelines you need before the exam. Try to see these guidelines, and also PDF files also is available. And another guidelines which is very important, which is joint of British Diabetes Societies and also European Society Endocrinology guidelines. Musa Sabah Sana. Okay. And don't forget that British Thyroid Association have a guideline for thyroid cancer, and also European Thyroid Association have a lot of important guidelines, especially for whom European board examination and also subspecialty. And the last reference for the question is MRCP part 1 and part 2. Endocrine question is very important, especially for part 2, because it is more difficult than part 1. So try to revise this a lot of times. Let's go to the macrovascular disease in the diabetes chapter, and don't forget that type 2 diabetes is equivalent to cardiovascular risk. Previously, we decided that everyone have a diabetes is have a coronary heart disease equivalent. And of course, diabetes mellitus have a significantly greater risk for macrovascular complications, for coronary heart disease, cerebrovascular disease, and peripheral vascular disease. And actually, 3/4 of people with diabetes will die as a result of macrovascular disease. So most of diabetic patients die from macrovascular complications. And as we know that once we diagnose diabetes, we must search for macrovascular disease, but the macrovascular disease may precede the actual diagnosis of diabetes by 10 years previously. So once the beta cell and insulin resistance occur, the macrovascular disease may occur at the same time. Of course, the incidence of macrovascular disease depends a lot of factors. The most important is the age and the duration of diabetes, the gender, the ethnic may affect the incidence of macrovascular disease. And previously, someone believes that cardiovascular disease is less common in type 2, in type 1 diabetes, but nowadays macrovascular complications occurs common as in type 2 diabetes. Don't forget that peripheral vascular disease occurs in up to 10% of patients with type 2 diabetes, and increase the risk, greater risk of non-traumatic amputation by about 15 folds greater. How to prevent the macrovascular complications? Secondary prevention by stopping smoking. Don't forget this. And of course, tight control of blood pressure and giving statin, and ill control of blood glucose. This is very important, which is known as a legacy effect of ill control of blood glucose can prevent macrovascular complications, as we see in some of the great trials like advanced study. And don't forget that aspirin, in a previous 5 years ago, we give aspirin for everyone of type 2 diabetes for primary prevention of cardiovascular disease, but nowadays aspirin is no longer recommended for primary cardiovascular protection in subjects with diabetes. We give aspirin only for patients with coronary heart disease or very high risk for coronary heart disease, and we will discuss it later in the guidelines published by European Society of Cardiology, and also in the NICE guidelines in the type 2 diabetes guidelines. Pathogenesis of macrovascular complications, one of them is the glycemic control. Once hyperglycemia per se increase the incidence of macrovascular complications, also the hypertension and dyslipidemia can affect, and there are a lot of trials which demonstrate this correlation between these disorders and the macrovascular complications. It is not very important actually in the exam. And also obesity and insulin resistance and altered coagulability can affect the macrovascular complication. And as what we learned from the United Kingdom in prospective diabetes study, EBEEDM study, that the major risk factor for coronary heart disease in patients with type 2 diabetes is LDL cholesterol. So every diabetic patients at some time need a statin therapy. Decrease the HDL cholesterol. Another factor is hypertension, hyperglycemia, and the smoking. So try to give medication and a lifestyle modification to try to decrease these risk factors as you can. This table actually is important in the exam. How to manage acute myocardial infarction. Usually be about 20 to 40% of patients admitted to hospital with myocardial infarction will have hyperglycemia. This is maybe undiagnosed type 2 diabetes and maybe transient hyperglycemia. So For every patient admitted to the hospital, we must check for random blood sugar. If it is elevated, we must check for glycated hemoglobin to diagnose diabetes or to try to diagnose it is acute hyperglycemia. For every patient, a tight glycemic control and try to let blood glucose between 7 to 10 millimole per liter for every patient by giving intravenous insulin and intravenous glucose at least 24 hours followed by subcutaneous insulin therapy. And this is from famous trial, which is the JAMI trial. Don't forget that it is suggested that all patients with blood glucose more than 11 millimole per liter will need glucose lowering therapy. So the target of blood glucose in the patient admitted to the ICU must be less than 10 millimole per liter. And of course, in using ACE inhibitor early after myocardial infarction have a lot of benefits for the heart. A lipid abnormality found in patients with diabetes, and actually we will discuss in the next Friday, inshallah, the lipid chapter. But this is unique for diabetic patient. Hyperlipidemia in a patient with diabetes is very important to treat it. At any level of cholesterol is associated with a greater risk of macrovascular disease than in a non-diabetic patient. In a patient, especially in a patient with type 2 diabetes, we will find that triglyceride is increased triglyceride containing lipoproteins like chylomicrons and very low density lipoprotein, which is calculated from triglyceride. Especially this dyslipidemia occurs more and more in a patient with poor glycemic control, especially in the type 1. Another abnormality is low HDL cholesterol, which is bad. Low HDL. HDL cholesterol is protective. So once the HDL is low, this is a bad condition. And also LDL cholesterol is increased, but a small increase in the LDL cholesterol. But the most important development of a small dense low density lipoprotein, which a particle of low density lipoprotein is small and dense. So LDL as a number will not increase more and more, but mildly increase LDL. But the most important in it, the small dense particle of LDL cholesterol. And don't forget that the other cause of lipid abnormality like familial hypercholesterolemia or familial combined hyperlipidemia must be excluded in a patient with type 2 diabetes. And this is a lot of trials for S and WASCOP and CURE and lipid trials, and all of them demonstrate that once you give a statin by any type of a statin to reduce the LDL cholesterol and or non-HDL cholesterol, we get a lot of benefits. For example, in this trial, reduction of even by about 55% for the diabetics. In non-diabetics, reduction is 34%. And in the WASCOP trial, 31% decrease in the reduction in the events. And in the CARE study, 24% for the patient with diabetic reduction in the primary endpoint. And for a lipid trial, 23% overall. So all trials demonstrate that once you give statin therapy, you will get a lot of benefits. So how to manage macrovascular complications? Patients with diabetes are given dietary advice to help control the blood glucose, which also contribute to improve the lipid profile. Other standard advice, this is for every patient, we must try to stop the smoking, reduce the risk of death by about 50% over a 15 years period. We must check and reduce the weight if overweight and obese. And actually, if we decrease the weight for a newly diagnosed type 2 diabetes by 6%, we can develop a remission of type 2 diabetes. Increase the physical activity, and don't forget that it is about 30 minutes per day for 5 days per week for every patient with type 2 diabetes, for every patient either type 1 or type 2 diabetes. lipid lowering therapy, the use of general cardiovascular risk stratification, this is very important, is not recommended for individuals with diabetes. And actually, in NICE guidelines have a unique parameters to giving statin therapy. They give statin therapy for type 1 diabetes if the patient have albumin excretion rate is elevated, or have two or more than two feature of metabolic syndrome or other risk factor. For example, if the age is more than 35 years or higher, high risk ethnic group. But for type 2 diabetes, here in the Oxford Handbook, they recommend statin treatment is recommended in all those more than 40 years of old, unless their cardiovascular is low. In this situation, if we calculated 10 years risk less than 20, this is a low risk, and the statin cannot be prescribed for this patient. And in those under 40 years with multiple cardiovascular risk factor, they must be given statin. And inshallah, in the next session, we will discuss it in more details according to the recent guideline. The treatment aims for the lipid. This is a area of controversy. Some guidelines does not recommend some targets, but in the Oxford Handbook, they recommend for diabetics and lipid parameter, total cholesterol less than 4. Don't forget that it is millimole per liter reference range. LDL cholesterol target is less than 2 millimole per liter. HDL cholesterol more than 1, and the triglyceride is less than 2.3 millimole per liter. This is the targets according to our reference book. And of course, the pharmacological intervention to increase the HDL cholesterol have not been shown to improve the clinical outcome. This is famous guidelines, which is MHI guidelines, which is for niacin, and actually the increase of HDL cholesterol by pharmacological therapy has no benefits in a clinical outcome. But the most important to increase the HDL cholesterol is weight reduction, and exercise, and stopping the smoking. In those patients with mixed hyperlipidemia, consider a fibrate or a statin license for the indication. Actually, we give a fibrate, usually fibrate, and this is very important. Fibrate will reduce triglyceride by about 30 to 40%. And actually, fibrate will decrease the LDL cholesterol by a small percent, about 20%. While statin usually act on the LDL cholesterol, and actually, statin therapy will decrease the LDL cholesterol by 25 to 35%. This is a moderate intense statin, but another statin, which is a high intense statin, will decrease the LDL cholesterol by more than 50%, and this is recommended for some types, some of our patients who have a diabetes and another risk factor for coronary heart disease. We must give a high intense statin. And don't forget, the combination of fibrate and statin can make some side effects, and don't forget that this combination is not usually recommended except in some specific indications. The combination of statin and ezetimibe may reduce the LDL cholesterol more effectively than increasing the statin dose alone, and this is already in recent guidelines that for some patients, and we will not reach the target of the LDL cholesterol by statin therapy. They recommend adding ezetimibe therapy for statin to decrease the LDL more and more. Hypertension, and actually in the session today, I will discuss the latest guidelines published by the NICE for the hypertension. Actually, it is released in the previous year. But hypertension is twice as common in diabetic population. Usually we see a patient with diabetes with hypertension, and if he has a hypertension, we must search for diabetes, because most of these disorders are presented together. And using cutoff points of this blood pressure more than 160 over 90 millimercury, hypertension occurring about 10 to 30% of the patient with type 1 diabetes and about 20 to 30% of microalbuminemic type 1 diabetes and 80 to 90% of the macroalbuminuric type 1 diabetes. And in Caucasian with type 2 diabetes, blood pressure, this is cutoff points which we make this numbers. 30 to 50% of Caucasian with type 2 diabetes have a blood pressure more than 160 over 90%. And using the EBEEDM suggests target of blood pressure is less than 140 over 80. Don't forget that this target of blood pressure in diabetics and non-diabetics, every year they change this number. So we must review the latest guidelines and try to follow it. Pathogenesis of hypertension, usually type 1 diabetes and hypertension is strongly associated with diabetic nephropathy and microalbuminuria and occurs at earlier stage than that seen in the many other causes of the renal disease. But in type 2 diabetes and hypertension is usually associated with insulin resistance and hyperinsulinemia. How to manage hypertension? Don't forget that this is the nice guidelines published 2015 for type 2 diabetes. They recommend that blood pressure target for diabetes should be less than 140 over 80 millimercury. But and we must bring the blood, our target blood pressure is less than 130 over 80 if there is a diabetic complications, diabetic nephropathy, retinopathy, or stroke, or other end organ diabetic kidney disease or retinopathy, especially diabetic kidney disease. But this number may be changed. We will discuss it later on, especially if the patient has no complications. They recommend the blood pressure is less than 140 over 90 millimeter mercury in the latest guidelines. And this actually, the guidelines published 2015, they recommend the blood pressure to below 140 over 80, but if there is a kidney or eye cerebrovascular damage, we must target blood pressure to less than 130 over 80. This is a 2015 guidelines. Don't forget that predisposing condition, other condition causing both hypertension and hyperglycemia should be considered. For example, if there is a manifestation suggesting of cortisol excess, we must diagnose Cushing syndrome as it can cause hypertension and diabetes. Also, acromegaly and pheochromocytoma. These three endocrinopathy can cause hyperglycemia and hypertension. End organ damage, we must search for end organ damage in any patient with diabetes. Try to search for retinopathy or coronary heart disease or diabetic kidney disease or peripheral vascular disease in particular every year. Assessment of cardiac risk factors, this is very important. Treat associated risk factor for coronary heart disease likely smoking, dyslipidemia, and sedentary life, and so on. A treatment of hypertension, in general, this is a very important. Modify other risk factors such as glycemic control, smoking, dyslipidemia. Then consider a weight reduction of obese. Reduce salt intake to less than 6 grams per day. And this number actually in some previous exams, they ask about a recommended daily intake of salt intake, which is recommended to less than 6 grams per day. And reduce alcohol intake to less than 21 units per week for male and less than 14 in the females. And of course, exercise about 20 to 40 minutes of moderate exercise 3 to 5 times per week, but the American recommendation and European recommendation about 30 minutes of exercise 5 days per week. Welcome, Dr. Ruben.
Assalamualaikum. Assalamualaikum, Dr.
Wa alaikum salam. How are you, Dr. Ruben? Nice to see
Alhamdulillah. I'm here only. I'm here only, Dr. Khalid. From the beginning, I'm listening to the this webinar.
How is Zohran?
Please carry on.
Okay.
Alhamdulillah, Alhamdulillah. He's fine, doing well. Alhamdulillah.
Pharmacological therapy for blood pressure, especially in the patient with diabetes, don't forget that ACE or ARPs, which is recommended if the patient cannot tolerate ACE, is very important as a first choice. And then adding a calcium channel blocker or thiazide. This is all the recommendation actually. And in the recent recommendation, they change this. They modify this choice. In the presence of microalbuminuria or frank proteinuria, ACE is the first choice, or ARBs if not ACE is not tolerated. In the Afro-Caribbean patient, ACE and beta blocker are less effective than the calcium channel blocker and diuretics. So they recommend the calcium channel blocker in a hypertensive Afro-Caribbean patient than the ACE inhibitor. But if the patient is diabetic, they recommend the ERBs as diabetic Afro-Caribbean patient. The ERBs is the first choice, not the ACE inhibitor in this situation. And this is a new recommendation in the latest guidelines published by the NICE. Several agents such as high-dose thiazide, the beta blocker, can worsen diabetic control and exacerbate dyslipidemia. So in the all NICE guidelines for hypertension, the beta blocker is the last choice to add for management of hypertension, except if there is a compelling indication. Actually, if the patient is coronary heart disease, in this situation, the beta blocker is have a first choice. But in if there is non-compelling indication for beta blocker, the beta blocker must be the last choice to add. Actually, we add spironolactone or high-dose thiazide diuretic before adding a beta blocker in the management of hypertension alone. In summary, to reduce the risk of macrovascular complication in diabetes, we must try to ease glycemic control to get benefits of legacy effect. And actually, we must strict glycemic control to achieve hemoglobin A1C as recommended according to the patient criteria, to bring it less than 6.5 if no hypoglycemia or life expectancy is good. Strict blood pressure control, and this is very important to prevent actually nephropathy and the diabetic retinopathy. And of course, the blood pressure target must be reached by mono or dual combination therapy. A treatment of dyslipidemia by adding a statin therapy or fenofibrate if a triglyceride is very high. Patients should be encouraged to lose weight, so healthy diet and regular exercise. And don't forget that aspirin therapy has currently no role in primary cardiovascular protection for a patient with diabetes, but continue to be used for secondary prevention. We at this time we finish diabetes chapter, and we will go to the guidelines, especially these guidelines published 2015 for type 2 diabetes in adults. And we just summarize the blood pressure management section in this guideline. For every patient with diabetes, we must measure the blood pressure at least annually. If a blood pressure, we must repeat blood pressure measurement to diagnose hypertension after within 1 month. If a blood pressure is higher than 150 over 90 millimeter mercury, within 2 months, if a blood pressure is more than 140 over 80, after 2 months, if a blood pressure is higher than 130 over 80, and there is a cerebrovascular damage or kidney or eye damage and organ damage, so we must recheck the blood pressure to diagnose the hypertension. And at the same time, we must provide the lifestyle modification, diet and exercise, but we did not prescribe antihypertensive as a medication except after confirmation of hypertension. Add a medication if lifestyle advice does not reduce the blood pressure to below our target. And in this guidelines, the target blood pressure systole is less than 140/80 diastole and 130/80 millimeter mercury if there is a kidney, eye, or cerebrovascular damage. We must monitor the blood pressure every 1 to 2 months and intensify therapy if the person is already on antihypertensive drug to bring blood pressure as we recommended previously. In these guidelines, they recommend first line antihypertensive drug should be once daily generic ACE inhibitor. Once daily generic ACE inhibitor. Exception to this are people of African or Caribbean family origin or women for whom there is a possibility of becoming pregnant. We must give an alternative to ACE inhibitor. The first line antihypertensive drug treatment for a person of African or Caribbean family origin should be ACE inhibitor plus either diuretic or calcium channel blocker. So don't forget this. For African or Caribbean family, we must start by a dual therapy. One of them, this is modified in the next guideline. Actually, they recommend here ACE inhibitor plus diuretic or calcium channel blocker. But in the latest guidelines, they recommend ARBs plus diuretic or calcium channel blocker. But here in this guidelines, they recommend ACE plus diuretic or calcium channel blocker from the start as a first line therapy for a person of African or Caribbean family origin. The calcium channel blocker should be the first choice in a patient with diabetes. For a woman for whom, after an informed discussion, it is agreed there is a possibility of her becoming pregnant. As we know that the ACE and the ARBs are contraindicated during pregnancy and preconception, but the calcium channel blocker is more safe than the ACE and ARBs. So if the mother prepared for pregnancy and hypertensive and diabetic, we must prescribe the calcium channel blocker. For a person with continuing or cannot tolerate the ACE inhibitor, for example, other than renal deterioration or hyperkalemia, cough, for example, we must prescribe ARBs as alternative for ACE inhibitor. And in all guidelines, there is no rule for combination of ACE and ARBs. If the person's blood pressure is not reduced to the individual agreed target in the first line, we must add a calcium channel blocker or diuretic, and this also is changed in the latest guidelines. Here they recommend if the patient is not controlled on ACE or ARBs, as we choose in the first step, we must add a calcium or diuretic. And diuretic, they recommend thiazide or thiazide-related diuretic. And they here recommend add the other drug that there is a calcium, add the other drug that is the calcium channel blocker or diuretic if the target is not reached in a dual therapy. If a person's blood pressure is not reduced to individual agreed target after combination of ACE or ARBs and the second choice calcium or diuretic, we can give a triple therapy with alpha blocker, a beta blocker, or potassium sparing diuretic. But this is the latest guidelines. This is published 1 year ago. Hypertension in adults, diagnosis and management. And actually, I reviewed these guidelines today and prepare it just today. This is the latest guidelines published by the NICE. And actually, I prepare all the guidelines, so I will review it now. So, how to measure blood pressure? It is very important. Some hints about it. If pulse is irregular, they recommend that measure the blood pressure manually using a direct oscillation over the brachial artery, especially in the patient with AF, for example. When measuring the blood pressure in a clinic or in the home, The patient must have a specific environment and provide a relaxed, temperated sitting with a person quiet and seated. And their arm must be outstretched and supported. And also, the cuff size must be appropriate for the person's arm. In people with symptoms of postural hypotension, falls, or postural dizziness, here they recommend to measure the blood pressure with the person either supine or seated. This is a one. And also measurement of another reading after the patient is standing by at least 1 minute for diagnosis of postural hypotension. If a systolic blood pressure is different from a supine or seated position than the standing position by more than 20 millimeters mercury, this is a postural hypotension. In this situation, we must review the medication. We must measure a subsequent blood pressure with a person's standing. We must consider referral to specialized care, and we must suspect, for example, adrenal insufficiency as a cause for this postural hypotension. How to diagnose hypertension according to this guideline? When considering the diagnosis of hypertension, we must measure the blood pressure in both arms at the first incidence. If the difference in reading between arms is more than 15 millimeters mercury, repeat the measurement. If another reading remains more than 15 millimeters mercury on the second measure subsequent blood pressure in the arm with the higher reading, and this is the reference arm for following blood pressure monitoring. Higher one. If blood pressure measurement in the clinic is more than 140 over 90 millimeters mercury or higher, we must take a second measurement during the consultation. If the second measurement is substantially different from the first, we must take a third measurement. And of course, in this situation, we must record the lower of the last two measurements as a clinical blood pressure. And at this situation, we cannot diagnose hypertension. We must read in another time. If a clinical blood pressure is between 140 over 90 millimeters mercury and 180 over 120 millimeters mercury, we must over ambulatory blood pressure monitoring to confirm the diagnosis of hypertension, and this is diagnosed as a stage 1 hypertension. If ambulatory blood pressure monitoring is unsuitable or unavailable, over home blood pressure monitoring to confirm the diagnosis of hypertension to exclude coat-white hypertension. While waiting for confirmation of diagnosis of hypertension by another reading, we must investigate for target organ damage. We must assess the cardiovascular risk using the cardiovascular risk assessment tool, which we will discuss in the next presentation, inshallah. And of course, a lifestyle modification, we must over a lifestyle modification once the blood pressure is elevated. Confirm the diagnosis of hypertension in people with a clinic blood pressure of more than 140 over 90 or ambulatory blood pressure is different than by 5 millimeters mercury systolic and diastolic. For diagnosis of hypertension, we diagnose hypertension for home blood pressure monitoring or ambulatory blood pressure monitoring by systole more than 135 and diastole by 85 or higher. So we must confirm the diagnosis of hypertension in people with a clinical blood pressure more than 140 over 90 or ambulatory by 135 over 85 millimeters mercury or higher. For every patient with type 2 diabetes, we must check the blood pressure at least annually. And we must, if we suspect secondary cause of hypertension, we must consider referral to specialist investigation. How to assess the cardiovascular risk and the target organ damage? According to guidelines, for all patients with hypertension, we must offer to test for presence of protein in the urine by albumin to creatinine ratio and test for hematuria using reagent strep, for example, to diagnose nephritic syndrome, for example. Take a blood sample to measure glycated hemoglobin, electrolytes, creatinine, estimated GFR, total cholesterol, and HDL cholesterol. Don't forget that NICE does not recommend the LDL cholesterol as a first target for us. They recommended total cholesterol and HDL cholesterol and calculation of non-HDL cholesterol. So in the NICE guidelines, they recommend to target a non-HDL cholesterol as a first lipid parameter for our patient. Examine the fundi for the presence of hypertensive retinopathy and also do ECG 12-lead electrocardiograph to be performed once you diagnose hypertension. Treat and monitor hypertension. The first one is lifestyle intervention. Offer lifestyle advice, diet and exercise, and of course alcohol consumption must be reduced if increased, and excessive consumption of coffee we must discourage excessive consumption or other caffeine rich products, and we must dietary sodium intake to bring it less than 6 grams per day, and don't offer calcium, magnesium, potassium supplementation to a patient with blood hypertension, blood pressure, elevated blood pressure, and also we must advise and help to stop the smoking. After that, we must know that in the NICE guidelines, all the guidelines published by the NICE, they classify the blood pressure into 3 stages. Stage 1, in which systolic blood pressure between 140 and 160, and the systolic blood pressure between 90 and less than 100 millimeter mercury. This is for clinical blood pressure measurement. And for home blood pressure measurement, this is decreased by 5. So systole between 135 to in the other arm less than 150, and the diastole between 85 to 95 millimeter mercury. This is stage 1 hypertension. Stage 2 hypertension is systolic blood pressure between 160 to less than 180, and the diastole between 100 to less than 120. And for stage 3 or severe hypertension, systolic blood pressure more than 180 or the systolic blood pressure more than 120. Don't forget this staging classification for hypertension, because when to manage depends upon which stage. How to start the blood pressure? Offer antihypertensive drug treatment in a patient with in patients by lifestyle advice and antihypertensive drug if for adults at any age with persistent stage 2 hypertension. So in stage 2, we must prescribe antihypertensive drug plus lifestyle medication once we see blood pressure systole more than 160 over 100 to less than 180 to over 120. So once the systole is more than 160, the systole more than 100, we must give antihypertensive drug plus lifestyle. But in a case of stage 1 hypertension, in this situation, the systole is less than 160 over 100, and the patient is less than 80 in age. In this situation, we can give antihypertensive drug if there is a target organ damage or established cardiovascular disease or renal disease or diabetes or estimated 10-year risk of cardiovascular disease of 10% or more. In this situation, we discuss starting antihypertensive medication for stage 1. But if this condition is not present, we must postpone adding antihypertensive for stage 1 hypertension to after confirmation of hypertension. Consider antihypertensive drug treatment in addition to lifestyle advice for adults aged under 60 years with stage 1 hypertension and estimated GFR less than 10. This must be considered adding this drug. Consider antihypertensive drug treatment in addition to lifestyle advice for people aged over 80 with stage 1 hypertension if their clinical blood pressure is over 150 over 90, using a clinical judgment for people with frailty or multimorbidity. For adults aged under 40 with hypertension, consider seeking specialist evaluation of secondary cause of hypertension, and don't forget that hyperaldosteronemia is the most common cause of secondary hypertension in this situation. How to monitor treatment and the blood pressure target? Here they measure standing as well as seated blood pressure in people with hypertension and diabetes, or posture hypotension, or age over 80 and over. In this situation, we must measure standing and seated blood pressure. Here, this is the recommendation: reduce the clinical blood pressure. This is the target in the latest guidelines, to bring the systolic blood pressure to less than 140 and the diastole is less than 90 millimeter mercury, and maintain that level in the adult with hypertension aged under 80. But for the patient with age more than 80, the target blood pressure is less than 150 over 90 millimeter mercury, and maintain that level in the adults with hypertension. How to treat and review when the type 2 diabetes is diagnosed? For an adult with type 2 diabetes on antihypertensive drug treatment, when diabetes is diagnosed, we must review the blood pressure control and medication used, and make it change only if there is a poor control. So, or if the current drug treatment is not appropriate. For example, if we have a patient with type 2 diabetes and well controlled on calcium channel blocker, don't modify this drug. Leave your patient on the calcium channel blocker if he is well controlled. But if he is not well controlled, change it to ACE or ARBs according. But if the patient already in the beta blocker and there is no compelling indication, it is appropriate to change this drug to ACE or calcium or ACE or ARBs or calcium channel blocker if indicated. How to choose antihypertensive drug treatment for people with or without type 2 diabetes? Don't forget that the isolated systolic hypertension was diagnosed if the systolic blood pressure is more than 160 millimeter or more. This is the isolated systolic hypertension, and the diastole is within the target. This how to treat the same treatment as people with type 2 diabetes, as people with raised systolic and diastolic blood pressure. When choosing the antihypertensive drug treatment, don't forget this is a unique for this guidelines. In adults of a Black African or African Caribbean family, consider ACE, ARBs, angiotensin II receptor blocker, in preference to ACE inhibitor. So in every patient with an adult of a Black African or African Caribbean family origin, in ARBs is the first choice, not ACE inhibitor, and this is a recent update for this recommendation. And this summary for the previous guidelines we discussed, which is published by the NICE 2016 guidelines for hypertension, and they recommend if this is the previous guidelines, not the latest guidelines. But I put this slide here to compare it with the recent recommendation. Previously, they recommend if the patient age is less than 55, we must prescribe ACE inhibitor as a first choice. If the patient cannot tolerate the ACE, ARBs is the next choice. If the age is over than 55 or a Black person or African or Caribbean, they recommend the calcium channel blocker as the first choice. If the patient is not controlled in ACE or calcium channel blocker according to each category, we must combine ACE and calcium channel blocker. ACE, of course, ACE or ARBs. If the patient is not controlled in the step 2, we must go to the step 3 by adding diuretic therapy. In the step 4, in resistant hypertension, we consider alpha blocker or beta blocker or seeking expert advice. This is the previous guideline. In the recent guidelines, they recommend adding therapy as the following. An ACE inhibitor or ARBs is recommended as a first step to adults starting step 1 antihypertensive for every patient with type 2 diabetes at any age or family origin. And if the age under 55, ACE or ARBs is recommended as a first choice, but not a Black African or African Caribbean family origin, because this situation, calcium channel blocker is the first choice if the patient is not diabetic. If diabetic, calcium plus ARBs. If ACE is not tolerated, ARBs is the alternate. Don't combine ACE and ARBs, and this is very important because it is unique for this guideline. Offer a calcium channel blocker to adults starting step 1 antihypertensive treatment if the age is more than 55 or over and don't have a diabetes, or the patient are a Black African Caribbean or African Caribbean family origin and don't have diabetes. This is, we must add a calcium channel blocker. If calcium channel blocker is not tolerated in this situation, the alternative is thiazide diuretic, and this is unique for this guideline. If there is evidence of heart failure, also they recommend thiazide like diuretic and also follow the guidelines published by the NICE on chronic heart failure. If starting or changing diuretic treatment for hypertension, they recommend indibamide is superior than bendroflumethiazide or hydrochlorothiazide. So they recommend a thiazide like diuretic indibamide. For adults with hypertension already on bendroflumethiazide or hydrochlorothiazide who have stable and well-controlled blood pressure, continue their diuretic as it is and don't convert them to indibamide. This is the step 1. In the step 2, they recommend before considering the next step, they must confirm adherence and the patient must have a full effective dose of this drug. If hypertension is not controlled in adults with step 1 in ACE or ARBs, offer a choice of one of the following drugs, calcium or thiazide. In the previous guidelines, if the patient is not controlled on the ARBs or ACE, the next step is adding calcium. But in this latest guidelines, they recommend choosing between calcium channel blocker or a thiazide like diuretic as a next choice, as a next step. I will show this step. The step 2 in the previous guidelines, they recommend after adding ACE, if the patient is not controlled in the RAS blockade, we must adding calcium. But in this guidelines, they recommend adding calcium or thiazide like diuretic as a next step. If the hypertension is not controlled in the step, if already the patient on calcium channel blocker and not controlled in the calcium channel blocker, in the previous guidelines, adding ACE or ARBs. But in this guidelines, adding ACE or ARBs or thiazide like diuretic, and this is updated recommendation. If a hypertension is controlled in adults of a Black and African or African Caribbean family origin who don't have diabetes, in the step 1, consider ARBs in the preference to ACE inhibitor in addition to step 1. The patient in the step 1 in the calcium channel blocker, in the next step, ARBs. The step 3 treatment strategy here, before considering the next treatment step for hypertension, we must review a person medication to ensure they are being taken at the optimal tolerated dose, and we must discuss adherence, compliance. If hypertension is not controlled in adults, taking step 2 treatment over combination of ACE or ARBs, so offer a combination. So if the patient is not controlled in the previous medication, we consider combination of ACE or ARBs plus calcium channel plus thiazide diuretic. So if the patient already in the ACE and calcium, we must add thiazide. If the patient on ARBs and thiazide, we must add calcium. If the patient already in the calcium and thiazide, we must add ACE or ARBs inhibitor. The fourth step, if a hypertension is not controlled in adults taking optimal tolerated dose of ACE inhibitor or ARBs plus calcium channel blocker plus thiazide diuretic, in this situation, we consider it a resistant hypertension. Before going to the next step, we must confirm elevated clinic blood pressure measurement. We must assess the posture hypotension. We must discuss adherence. For people with confirmed resistant hypertension, consider adding a fourth antihypertensive medication. The fourth one, we must consider further diuretic therapy with low dose spironolactone. So the fourth drug, low dose spironolactone. When using a further diuretic therapy for step 4, we must monitor the blood sodium, potassium, and renal function. Consider alpha blocker or beta blocker as a last step for adults with resistant hypertension starting step 4 treatment. If blood pressure remains uncontrolled in people with resistant hypertension taking the optimal tolerated dose of 4 drug, we must seek specialized advice. So this is how to start antihypertensive medication for a patient with hypertension according to the latest NICE guidelines for hypertension, and this is the target they recommend in these guidelines, and they have a lot of paragraph why they choose the committee of this guidelines choose to return to the 2011 clinic blood pressure targets, which is blood pressure systole less than 140/90 millimeter mercury for adults under the age of 80 years was retained and applied to people with or without diabetes. So they recommend the target of blood pressure to the patient with or without diabetes to this targets 140/90 millimeter mercury, and of course home blood pressure monitoring, the target is less than by 5 systole and 5 diastole. But if the patient have a diabetic kidney disease or the patient have end organ damage, the target of systole is less 130/80 millimeter mercury, and of course they give a lot of evidence in this guideline. I have just a few slides for summary for the European Society of Cardiology guidelines, which is published in 2019 for on diabetes, pre-diabetes, and cardiovascular disease. I just reviewed the parameters or change from the previous guidelines and the recent guidelines about the blood pressure targets. And actually they here in the previous guidelines, they recommend the blood pressure target to less than 140/85 for diabetic patient. But actually in the recent guidelines, they will individualize the blood pressure targets are recommended. They recommend the blood pressure target systole of less than 130 millimeter mercury, and if well tolerated, and to less, but systolic blood pressure must be more than 120, but not less than 120. In older people, a target blood pressure between 130/140 millimeter mercury, and the diastole is less than 80 millimeter mercury, but not less than 70 millimeter mercury. And this is according to the European Society guidelines. And you see that all the guidelines have a specific targets for blood pressure. And every year, every guideline changes the targets and go to the previous one, and so on. And on the treatment of systolic blood pressure to less than 130 millimeter mercury should be considered for patients with high risk of cerebrovascular events or diabetic kidney disease. They recommend the same target of systolic blood pressure less than 130 millimeter mercury. And this is actually all guidelines recommend this target for the diabetic kidney disease patient. And also a lipid targets, they in the previous targets, as we mentioned previously, but in the recent guidelines, they recommended type 2 diabetes with at moderate cardiovascular risk LDL cholesterol target of less than 2.6 millimole per liter, and by milligram per deciliter is less than 100 is recommended. In patient with type 2 diabetes with high cardiovascular risk, LDL target is less than 188, is less than 1.8, which is equivalent to less than 70 milligram per deciliter, or at least a reduction of LDL cholesterol by more than 50%. In a patient with type 2 diabetes at very high cardiovascular disease, the LDL target will be less than 1.4 millimole per liter, or less than 55 milligram per deciliter. And actually, this is the same as ACE guidelines for type 2 diabetes and dyslipidemia recommendation. Antiplatelet therapy, antiplatelet therapy for primary prevention is not recommended in diabetes at low cardiovascular risk. This is the previous guidelines published by European Society of Cardiology. But in the recent guidelines, they recommend the aspirin only for a primary prevention, which may be considered in patients with diabetes at very high risk or high risk in absence of a clear contraindication. In a patient with a very high risk or high risk for development of cardiovascular disease, if there is a clear no contraindication. But aspirin for primary prevention is not recommended in patients with diabetes at moderate cardiovascular risk. This is the last slide. عندما يكون لديك هدف سامي في الحياة ويكون لك مآثر أسعدت بها الغير، فهذه السعادة الحقيقية. And don't forget that this is the YouTube channel, which I upload every session on it. And this is my last slide. And inshallah, in the next Friday, I will discuss in more details the dyslipidemia chapter. And actually, I prepared it today, but I think it need more illustration and more to let it more clear, inshallah. If anyone have any question, it is welcome.
ألف شكر دكتور خالد، ربنا يبارك في حضرتك، يعني متألق كالعادة والله.
ربنا يبارك فيك يا باشا. دل مين؟
سامح سعود.
يا اهلا وسهلا دكتور سامح. اصل الجهاز بتاعك ظاهر قدامي دل بس مش
النهارده داخل من اللابتوب مش داخل من الموبايل. بس أذنك كان في سؤال بالنسبة قلت البحث السنة اللي فاتت، في تغيير ولا لا الميتفورمين افتر ام اي؟
والله احنا اخر اتفاق اللي اتكلمنا فيه الميتفورمين is allowed actually once the patient is discharged from the ICU he can take metformin with no if there is no contraindication. Actually it is safe and protective and cardiovascular protective actually.
وده كان اخر حاجه اتفقنا عليها السنه اللي فاتت. هل ده
هو لا هو ده اللي اتفقنا عليه وهو ده الليتست. And actually I ask a lot of professors of diabetes pioneers worldwide and they recommend the metformin after acute myocardial infarction after discharge from the hospital. If there is no contraindication, don't prescribe it. If the patient ejection fraction, for example, heart failure and advanced heart failure, of course, in this situation, metformin is not a choice.
طيب بالنسبة لي اللي هو المريض اللي هو ادميتد للام اي وما كانش مش معروف قبل كده ان هو في دايابيتس او لا، بيقيس السكر اللي هو مثلا 11، قاسوا مرة تانية برضه في الحدود دي 11 12، فهل ده بنبدأ معاه على طول فاريبل ريت ولا بنستنى عليه مثلا ولا بنبقى ايه وضعه؟
Once the blood pressure hyperglycemia documented hyperglycemia in more than one reading, more than 10 millimole per liter, start variable rate or start diabetes medication. Actually, it targets blood pressure in all guidelines in the patient admitted to the hospital or especially intensive care unit. Between the blood sugar between 140 milligram per deciliter to less than 180. This is the recommendation, and they recommend to be between 110 to less than 180. This is by milligram per deciliter, and you can convert it to by millimole by
7 ل 10 مليمول.
يعني الارقام this is the recommendation. Blood sugar in for every patient admitted to the ICU. So if you check blood glucose and you find it is, for example, 11 millimole per liter, and repeat it after 1 hour and it is elevated, you must start antidiabetic medication, insulin, for example, according to your situation. If in the ICU, you must give insulin therapy, variable rate insulin therapy infusion in this situation. And of course, at this situation, you must order hemoglobin A1C to check if it is diabetes and diagnosed nowadays, or it is just hyperglycemia due to the stress. But in both situation, you must start variable rate insulin infusion.
طيب بس أذنك بالنسبة لي اللي هم الجيستيشنال دايابيتس.
الوات؟
لو هي
لا انا ما سمعتش، انا ما سمعتش
مثلا نحلل
ما سمعتش يا دكتور سامي.
الجيستيشنال دايابيتس.
يس.
الجيستيشنال دايابيتس.
يس.
لو بتحلل وبتلاقي مثلا اللي هو الفاستنج بتاعها 7 او مثلا من 7 ل 8، او البوست برانديال بتاعها بيكون مثلا 8 ل 9، لكن مفيش كومبليكيشن لسه ظهرت او هي في الفيرست تريمستر مفيش اي كومبليكيشن، لا ماكروزوميا ولا في اي حاجه، هل بنديها انسولين ولا بنديها ترايل الاول؟
لا actually the guidelines the actual once you diagnosed hyperglycemia in the first trimester, this is mostly pre-gestational diabetes, because gestational diabetes per se, this gestational diabetes usually occurs in the second half of the pregnancy. But once you diagnose it in the first trimester, this is actually pre-diabetes or pre-conception diabetes diagnosed during the first trimester. Once in fasting blood sugar is more than 7, you must start by insulin therapy. Actually, in the gestational diabetes and the guidelines published by the NICE in 5 years ago, it is a clear guidelines, and we will discuss it actually in one of our previous sessions. In the gestation
انا فاكر انا التارجت ان هو لو الفاستنج اكتر من 7 او يساوي 7 ده بنبدا انسولين.
يس.
لكن المشكله ان هو في بعض الاسئله وبعض اللي هو البنوك لغايه دلوقتي، حتى لو البنوك اللي هي الحديثه، هو اوكي بيقول ان النايس جايد لاين بيقول ان هو التارجت بتاعنا ما يعديش اللي هو ال7، لكن طالما ما فيش كونتر انديكيشن احنا ممكن نمشيها اسبوع ترايل على الدايت او اللي هو على الميتفورمين، واذا ما اتحسنتش نبدا انسولين.
In this situation, if the fasting blood sugar is less than 7, but once in the fasting blood sugar more than 7, actual lifestyle per se does not bring this to the target number. If the fasting blood sugar is more than 7, you must start insulin immediately with lifestyle modification. And actually, we start by small dose of insulin therapy. But if systolic blood pressure is less than 7, you must try lifestyle modification for 1 week by diet and exercise if acceptable by gynecologist. If not controlled and reach the target, you must start insulin therapy in this situation.
شكرا جدا لحضرتك دكتور خالد.
I have just a problem with WhatsApp group, so I will upload the presentation. I will try to solve this problem, but actually in the previous 2 weeks I have a problem with WhatsApp group, so I will upload the presentation to the Telegram group, and someone please upload it to WhatsApp group. Inshallah. Yes, Dr. Rubaid.
Dr. Khalid, can you please share the BMG source of examination for the SCE and EBEEDM?
Okay, I will share
Telegram group, no problem.
Okay, I will share all the sources I have in the media fire. I have a folder in the media fire, have all sources and all banks. So I will share this bank, and everyone can share it for everyone.
Thank you, Dr. Khalid.
See you later, inshallah. Inshallah, in the next Friday, we will discuss dyslipidemia. I hope everyone try to read it, because it is very difficult, and actually in the exam, the question of dyslipidemia is very difficult. So try, because you need to know which a lipid parameter increase and which is have some pathognomic features in each type. Inshallah, we will meet in the next. Do you recommend next Friday or Saturday?
Saturday.
المهم يكون
خلاص ساتردي، ما دامت روبان ساتردي يبقى اوكي ساتردي ان شاء الله. اوكي. السلام عليكم، نشوفكم على خير ان شاء الله. السلام عليكم.
Thank you, Dr. Khalid.
السلام عليكم. اوكي. السبت ان شاء الله. السلام عليكم.